I want to talk about restraints next. It's part of our safety section that we're learning about because restraints, we tend to think of restraints as being something that's going to keep our residents safe, but we're finding that that really isn't the case many times. Restraints used to be used when people would pull out equipment, when they would try to climb out of bed, anytime they were confused or showed any type of poor judgment. But more people are seriously hurt trying to get out of restraints than they were without them ever even being on. When I first became a nurse, we used restraints a lot. If our patient tried to climb out of bed, we'd remind him not to do it without help. If they did it again, we'd tie him up. We thought we were keeping them safer. If they couldn't fall, they couldn't break their hip, they couldn't hit their head. But what they found is, people are Houdinis with these restraints, and they get so agitated and so upset that we were having more problems with the restraints than we were by not using them. And it's not that the restraints won't ever be used, because they can be. Restraints can still be used, but we have to show that we tried alternatives, that we tried different types of techniques and things we could do to try to keep the person from needing restraints. They can never be used as a discipline or a punishment, and they can never be used for a convenience for us. So when we're looking at a person with restraints, I thought this was cute. It says the restraints are for your own protection, Mr. Norris. We're concerned that if you ring the nurse's station one more time, they're going to strangle you. There are times you'd love to tie your residents up, believe it or not, but that is just obviously an unethical thing to do. And even if they are, causing you frustration and stuff, there are always better ways to take care of them. So what causes harmful behaviors? Well, people are in pain or their illness. Lack of oxygen. When a person has lack of oxygen, which the term is called hypoxia, when you don't get enough oxygen up to the brain, you don't make good decisions. You may get confused. You may get lethargic, where you're really fatigued and tired. Patients are scared. They need to go to the bathroom. They're hungry or thirsty. They might have communication issues. There might be side effects from the medications they're taking. So all of those can lead to harmful behavior that we might be seeing. So if we can take care of the harmful behavior, if there's something causing it, so if I go back here, if it's from lack of oxygen and the nurse gives them more oxygen, maybe we can take care of it. Or if they're hungry or thirsty and we take care of that, maybe we can fix that problem. So we always want to try to fix the problem first if we can. If we can't, and we're thinking we may have to restrain them for safety, we need to try alternatives first. So we have to try a variety of different things to try to keep our patients safe without needing restraints. So diversion, watching TV, taking them to activities, letting them do some art, getting them involved in something. Following routines. Patients that have dementia, that have really bad confusion, they tend to do better if you follow their normal routines. So finding out what their routines are from their family and trying to stick to those are sometimes helpful. Encouraging the family to come and stay with them. Or activities. Again, take them into that activity room. Try to get them involved in something to take their mind off of whatever's irritating them or agitating them. Answer call lights promptly. That hourly rounding we talked about, pain, potty, position. Doing hourly rounding will catch a lot of people that are trying to climb out of bed and hopefully meet their needs, so we don't need to do restraints. You'll see some of the residents will be put near the nurse's station. We get them up in a chair, we put them near the nurse's station. And, I've had some students say, well, I think that seems kind of undignified. And I think depending on what's going on with them, it could be, but in other ways, it's an actually safe alternative. If they're sitting near the nurse's station where there's lots of people walking by them, they're constantly being watched and checked on. Exercise programs. Tasks to do. We used to have a resident who used to pick at all of her tubes, and so they were having to kind of tie up her hands or put mitts on. And what we used to do is we used to just give her a basket of laundry to fold, and we'd ask her to fold it, and she was thrilled to do it, thrilled to do something to help. And she'd fold up all the washcloths nice and perfect, and we'd take them out of the room, and we'd just fluff them all up again and take them right back in there, because obviously we couldn't use it since she had touched it. It's not like we could use it for the other residents. But it gave her a task to do, gave her something to feel worthwhile, and kept her hands busy, so we didn't have to tie them up. Warning devices on doors and tab alarms, reorienting them, where they're at, what's going on. Roll guards or pads sometimes can be used just to help keep them from rolling off of the bed, or pads on the floor in case they do fall off a bed. Glasses and hearing aids, and just making sure we're giving good care and explaining our procedures. If we do have to use restraints, if there really isn't an alternative, you need to imagine what this might be like if you were in restraints. If you were in restraints and you were tied down and strapped down, and let's say a fly's buzzing around you or landing on you, or you hear the fire alarm go off, or you're hearing your phone ring but you can't pick it up. I mean, it's very frustrating, and people get even more restless and more agitated in these restraints, and they fight you even more. So always remember to treat people the way you would want, with kindness, with caring, with respect, and with dignity. So some of the types of restraints we see, there's geriatric chairs, there's bed rails, sheets tucked so tight that they can't move. Okay. That is actually considered a restraint. You tuck their sheets and blankets in around them so they're so tight that they can't even turn or move. That is considered a restraint. The bed rails we already talked about. We used to not look at as the top two as a restraint, but now they are starting to look at them that way. So if the person wants those top two up, they're going to have to sign for it. A geriatric chair is a chair that will recline back. So it kind of reclines almost like a stretcher, and you can slide the patient over from bed to the chair. Well, if you keep that chair in a where the head of the bed is hardly up, most residents can't get out of bed that way. So it can be considered a restraint. So part of this is going to be, how are we using it? So for instance, those bed rails, if we're just using those upper rails and we're doing it because the patient wants them for positioning, it would be considered a positioning device. Where if we're putting up all the rails around the bed to keep them from climbing out, then it's going to be considered a restraint. Wheelchair locks, if they can't unlock them themselves, that is considered a restraint. And drugs can be considered a chemical restraint. If you have a patient who's agitated and the nurse is giving them all kinds of sedatives to keep them knocked out so they can't climb out of bed, that is a chemical restraint. So an enabler device, this for instance is that Jerry chair I was talking about. You can actually set it all the way flat, so you can slide your patient from bed over into it, and then you can sit them up so it will function a little bit more like a chair. But if I keep them if I recline that back even a little bit more, it's going to be really hard for a person to be able to get up and out of that. So if I'm using it specifically to restrict their movement, then it can be considered a restraint. If I'm doing this because, I want to get them out of bed, they aren't capable of sitting all the way up. Let's say they've lost all their upper body strength and they're tipping forward, or they're keep falling out of the bed. Then it could be considered actually considered a positioning device for them, something to actually help them move easier and promote independence. So part of it, when we're looking at something, is it a restraint? Is it a positioning device? We need to look at the intent of how it's being used. So some of the problems we see with restraints, we see people get tangled up in the bed rails. I've never seen this one where they've gotten actually through the bed rail, and I actually haven't seen that one either. But I have seen this one here, and I've seen this one here, and I've seen this here, and this one here. So there are problems with restraints. One of the things that has happened in the past is we've had patients that have been on vest restraints, and they've gotten partially out of the vest, and they've gotten out of it enough to where it's come up around their neck, and they've hung from it, as they were trying to climb out of bed. So people have died because they've been in restraints. And so this is always a huge issue, and so something we want to avoid if at all possible. As far as legal aspects of restraints go, the restraint has to protect the person. So a doctor's note is required. Now, a CNA can never initiate restraints. It is not your choice or your decision whether or not a restraint should be used or initiated. An RN can initiate restraints so long as they call the doctor and get an order from the doctor within an hour. The least restrictive device has to be used, so your clinical instructor will be showing you some of the different devices that we have, some of the different restraint devices that are available, and that you have to use whatever one can get the job done with the least amount of restriction. We use only after other measures fail to protect them. Unnecessary restraint is considered false imprisonment. So if you're restraining someone when they really don't need to be and you're doing it as a convenience for you, it is false imprisonment. And anytime we do put a person in restraints, we end up having to notify the patient as to why it's happening, and we need to notify the family as well. So some basic safety guidelines if we do use restraints is we have to follow the manufacturer's instructions. We have to check the person every 15 minutes. So here you're putting this restraint on thinking it's going to make your life easier because now this person's not climbing out of bed. Well, now every 15 minutes you've got to go in and check on them. Every 2 hours you have to go in and release the restraint and reposition the person, meet their elimination needs, offer food and fluids, skin care, range of motion to that part that was tied up, provide comfort, and then put the restraint back on. So you're going to find that putting a person in restraints does not actually make your day go quicker. As far as reporting and recording, and we said reporting is the oral account of something, recording is the written account. We need to make sure that what is recorded is the type of restraint used, the alternatives that were tried first, the time the restraint was applied, the time you remove the restraint, skin color and condition below that restraint of their extremity, the pulse at or below the restrained extremity. So if I'm tying their arm down, if I'm putting a wrist restraint and tying it down, I need to check the color and sensation to the fingers below that restraint. I need to check that pulse in the wrist to make sure I'm not putting that restraint on so tight that it's cutting off circulation. I want to look for changes in behavior and any complaints of difficulty. So here are some types of restraints we see. These leather restraints are very rare. I've only ever seen those used in the emergency department when someone is kind of becoming extremely aggressive due to medications. But soft wrist restraints are used quite a bit to keep people from picking at tubes, to be able to keep people from pulling their tubes out. These mitts are also, a mitt would be a type of least restrictive device. And those, the person can still move their arms and their wrists, but they can't grab onto tubes. If you have IVs and tubes in little kids, sometimes they'll put these arm restraints on, so it keeps them from being able to bend their elbow, so they can't bend their elbow to get it into where the tube is to restrain it. But you always have to follow manufacturer's directions. You have to make sure that you know how the restraint works correctly. A vest restraint, there are types of vest restraints that zip in the back, and then there are these types that actually cross in the front. It allows the person to still roll from side to side and move their arms, but they can't actually crawl out of bed. And then they make a waist roll one where they can roll from side to side, but it stops them from actually crawling out of bed. So we will stop there, and that will end our section on restraints.